welcome all the delegates and the participants who have joined for this GastroScope webinar. I'll just share my slides to introduce our today's moderator. So welcome again to our GastroScope webinar. The topic for today's webinar is Cholestyramine Reimagined, New Roles for a Trusted Therapy. And to discuss this scientific forum, we have, to take it ahead, this scientific forum, we have our moderator, none other than Dr. Ashok Dalal, who is the professor of J.B. Pant Hospital, principal investigator of various clinical trials of ulcerative colitis, Crohn's disease. He has also been awarded as a Professor M.P. Mehrotra Gold Medalist in the year 2011, postgraduate in clinical medicines, and along with that, he has almost more than 60 publications in his name. So I welcome Dr. Ashok Dalal to take the scientific webinar ahead. Over to you, sir.
If you can share the slides for other speakers also. The same slide has got all the information.
Sure. I'll just do that.
Okay. Thank you, Ajanta Pharma. First of all, I'd like to thank you all bring this topic today for discussion, because this topic, cholestyramine, is not a new topic basically, but still so many indications still there. It is not so commonly used. Cholestyramine, if I'm not wrong, came in early 1950s. Indications came in all 1970s, and still it has not got that recognition in the physicians, among the physicians, which it should have got. So sometime we call the forgotten molecule. So to talk about this therapy and its usage in today's clinical context, we have Dr. Amarender Singh Puri. Ideally, Dr. Puri doesn't require any introduction. He was the head of Department of Gastroenterology in G.B. Pant and was my teacher, also my mentor and guide. I first used cholestyramine under his guidance, and he is an astute clinician. Means he take care of patients like anything. He dedicate his time to the patient, and diagnose them properly. And I saw him using cholestyramine, using for so many conditions. I learned from him. Work has set benchmarks in management of all these disorders. So Dr. Puri has been awarded by Delhi government Meritorious service, and career is a rare combination of academic excellence, clinical mastery, and a visionary leadership that he provided at GB Pant. Presently, he is working in as vice chairman in Medanta. So, along with sir, as speaker about this molecule, we also have an esteemed consisting of A.V. Siva Prasad. Again, Dr. A.V. Siva Prasad is a very senior gastroenterologist. He did his DM gastroenterology from AIIMS Delhi. And he was the first gastroenterologist that he started practicing in the current Andhra Pradesh. And he has a very good wealth of clinical and academic experience. And I'm sure that he will share his experience of his journey of cholestyramine all through these decades. And after Dr. A.V. Shiv Prasad, I would like to introduce Dr. Rishikesh Malokar. Dr. Rishikesh is a young gastroenterologist. He is the assistant professor at TNMC and Siva Hospital, Mumbai. He's a dynamic young fellow, and he has cleared off many exams and doing good work really. And he's now doing a lot of clinical trials. After that, we are moving to the east to the city of Joy, from where I would like to introduce Dr. Devani Sakar, the gastroenterologist in Kolkata, practicing in Kolkata, and he is a member of all the various societies, and he is a senior consultant. So with this, I would like to ask Dr. Kesa to start his presentation.
Thank you, Ashok, for the kind introduction. Am I audible, please?
Yes, sir, you are audible.
That's fine. Can we have my slides? can put them on full screen, please. Thank you. So in the next half an hour or so, I'm going to be talking about a drug that we are all very familiar with, cholestyramine, and which in India is available through Ajanta Pharma as Coltran. Next slide, please. This is the outline of my talk. Don't get daunted by the long list of 13 things. I am briefly going to talk about the mechanism of action, pharmacology, and as far as gastroenterology is concerned, we will be focusing on bad things. Bad stands for bile acid diarrhea and management of cholestatic pruritus. And finally, I will end by giving 3 or 4 case histories and the way cholesterol or cholestyramine made a difference in the life and especially the quality of life of these patients. Next slide, please. So, although the drug is more than 50 years old, but still some aspects of the drug, and especially its role in bile acid,
50 years old, cholesterol.
uh, and especially in its role in bile acid malabsorption, and now is being increasingly appreciated. And it is another drug that is useful in patients who have bile acid malabsorption, which overlaps or sometimes it gets neglected because it is thought of as IBSD. Next slide, please. So this, I think Ashok has already alluded to this slide. The way I look at it is it's some kind of a metamorphosis. We know we are very familiar with the metamorphosis of how a larva becomes a pupa and the pupa becomes the butterfly. And when you see the end result of the butterfly, nobody can imagine that what it started off as. So in the 60s, 50s, and 60s, this was started off, it was born or it was discovered as a cholesterol lowering drug. Unfortunately, that role seems to have gone out of picture. Now we have better drugs. The statins have come in a big way, Febustat, etc. So this role is forgotten. But approximately at the same time, it was also recognized its anti-protetic properties, in which Dr. D.V. Datta from India, who later on became the chief of hepatology at PGI Chandigarh, he had a very seminal role in the first paper that was published on anti-protetic properties. I'll be discussing this paper in some detail in the course of my talk. Then in the 70s, it was recognized that it is also a very useful drug in bile acid induced diarrhea, or bile acid diarrhea bad as we call it. And it took almost about 15 years for the FDA to give approval for hypercholesterolemia. Next slide, please. Now, let me take you back to your days of physiology. Whenever we eat a fatty meal, then that fatty meal, by the virtue of cholecystokinin, the bile is released into the duodenum. The bile contains bile acids. These bile acids, they reach the small bowel, and then in the ileum, most of them are reabsorbed. Now, I will go and discuss about the physiology in some detail in my next slide, but most of it is reabsorbed into the portal vein, and only 0.5 grams is excreted in the feces. And so it goes into both the systemic circulation as well as into the liver, and that's how we have the enterohepatic circulation. So if for some reason you had a drug like Coltron, which binds the bile acids, then these bile acids, because they are now bound to Coltron, they will not be reaching the ileal receptors, and instead this compound that is so formed between Coltron and bile acids will be excreted in the stool. And the body and specifically the liver recognize, because there is a shortage in the enterohepatic circulation, so the liver tries to compensate by producing more bile acids. And what is the raw material from which these bile acids are made? That is cholesterol. So indirectly, the cholesterol lowering effect is what it started. That's how it was discovered. And additionally, in patients who have intrahepatic cholestasis of pregnancy or cholestatic viral hepatitis, these bile acids, they are in the skin and they irritate the skin and cause pruritus. So if we lower the bile acids by a sequestering agent, the pruritus gets alleviated or gets relieved. Next slide, please. Now, again, going into the pathophysiology, on your right of the screen, you will see an enterocyte. The enterocyte, as you can see, has got this hair on end appearance, which is the bile, which is the villi. And on this brush border, you can see that there is a receptor. And this receptor is known as ASBT. People in Delhi are very familiar with ISBT, and this is known as ASBT. Now, why is it known as ASBT? Because this cell, the enterocyte, the brush border, is on the apical segment, and this is on the basolateral membrane. So when the bile acid comes, it binds to this receptor, and the name of this receptor is apical because it is situated on the apical aspect, not on the basolateral aspect. S stands for sodium dependent. So it's a sodium dependent channel. And BT for bile acid transporter. So when the bile acid, which acts, the ligand binds the receptor, enters the cell, goes into the cytoplasm, and just where, if this can be taken as a bile acid importer, then this is a bile acid exporter. So this is OST alpha and OST beta. They are excreted, they help in the excretion of bile acid into directly into the portal vein. So as I mentioned, because of the enterohepatic circulation, only less than 1 gram of bile salts enter the feces and fecal excretion occurs, which is the main or the only mode of excretion. Next slide, please. So again, discussing the pharmacokinetic profile. As I said, this drug is not absorbed. It doesn't go into the blood. You cannot measure its blood level. And it is distributed only in the small bowel and in the large bowel. There is no metabolism because it is not absorbed, and it is eliminated in the feces. The advantages of it being a non-absorbable drug is it will not have any drug interaction and it will not cause any blood-related hypersensitivity reactions. Next slide, please. So there are several indications for using Coltran or cholestyramine, but I will stick in today's talk on the gastro aspects, which is cholestatic pruritus. And let me tell you and let me remind you that the commonest cause of cholestatic pruritus is not primary biliary cholangitis. It is cholestatic viral hepatitis in India. Both hepatitis A and hepatitis E can have significant pruritus in a fair proportion of these patients. And the patients are not bothered about the yellow color of the eyes. They are bothered because they cannot go to sleep and they scratch and cause excoriations. Sometimes they even get secondary infected. The second indication for its usage is bile acid diarrhea, which I will discuss in some detail in my subsequent slides. Next slide, please. So, bile acid diarrhea, why does it occur? It's because when there is excess bile acids, they are not absorbed by the ileum, they enter the colon, and in the colon, they act as a secretagogue. So the colonocytes, they will secrete water and chloride, and that's how it causes a diarrhea, because it increases the water content. So this is a common feature in IBS-D, in sometimes in post-cholecystectomy patients, specifically in patients with Crohn's disease who have extensive involvement, because Crohn's disease is one disease, unlike tuberculosis, which causes long segment involvement of the terminal ileum. So you can imagine if the whole terminal ileum is diseased, then the receptors, the ASBT receptors that we were talking of, they're all damaged, and bile acids do not bind to these receptors, and they are excreted as such and reach the colon. Now, if you look at the bottom half of this slides, it says hepatic overproduction of bile acid. Now, this is distinctly uncommon, but to explain this fact, it is as if there is a windfall and the liver suddenly starts producing so much excess bile acids that the receptors that we talked about in the ileum, they get saturated, they are outnumbered, and the excess bile salts, they reach the colon, where they cause chronic watery diarrhea, they can cause flatulence, they can cause urgency, and sometimes even incontinence. But this is distinctly uncommon. The more common situation is when you have extensive ileal resection. In India, at one time, for ileocecal tuberculosis, extensive resection of the ileum was done. But luckily, despite the resection of a fair amount of the ileum, we hardly ever saw patients with bile acid diarrhea. The more common situation today in 2025 is when you have extensive resection of the terminal ileum, and the most important disease here would be Crohn's disease. So when you have a, a, a disease which involves extensive ileum, it causes secondary bile acid diarrhea. So I talked about primary bile acid diarrhea, which was because of overproduction, and a secondary bile acid diarrhea because of malabsorption, because the terminal ileum isn't there. Either it is not there because it has been resected, or it has been damaged and the brush border is beyond repair. It doesn't have the the receptors. Next slide, please. Then, next slide, yeah. This is an important question, and we are talking about bile acid diarrhea. And the question naturally arises, I doubt if anybody has actually seen a case of completely diagnosed with the gold standard for bile acid diarrhea. And why is it so? So the question that arises is, why is the diagnosis of bile acid diarrhea so difficult in India? And the answer is that the gold standard for the diagnosis of BAD or bile acid diarrhea is the selenium HCAT scan. And to the best of my knowledge, this nuclear medicine test is not available anywhere in India. So we don't have the gold standards. And of the other four, if I can call them surrogate markers, or if I can call them silver standards, then of the four, three are not available in India, and I will not talk about it. So serum FGF, urinary VOCs, and fecal bile acid test, maybe some or one or two research labs, maybe AIIMS might be doing it, but rest commercially available, they are just not available. So what do we have that is left amongst the surrogate markers or the silver markers? Silver standard, if not marker, is the serum C4. And in most recent publications, even they do not have access to the selenium HCAT scan. So serum C4 level greater than 52 milligram per liter is taken as a surrogate marker for BAD. So if you have a patient who has a bile acid diarrhea, then it is worthwhile. If you want a specific treatment, you just order this test. And everywhere serum C3, serum C4 are available because they are used so extensively thanks to the immunology department in most places. So because this test is so widely available, I think this is the surrogate marker that we can use in India and prove, at least if not the gold standard, we can have a clinical diagnosis, because this is one condition, perhaps the only condition, in which the serum C4 is increased. In all the immunological conditions, it is decreased. So this is perhaps the only disease, only condition where the serum C4 is increased. Next slide, please. And importantly, it is thought that in IBS diarrhea, approximately 1/3 of the patients may be having BAD or bile acid diarrhea. Now, I don't think we have any data from India to say what proportion of patients of IBS-D. IBS-D means you have to have pain and you have to have the diarrhea, which is non-bloody. And of course, we have whether you want to use the Rome criteria or you want to use other criteria. So the Western literature, several references I looked up, and all of them have come up more or less with the same figure, that approximately 1/3 of the patients of IBS-D would actually be due to a BAD. Functional diarrhea means exactly the same thing minus the pain. So a fair proportion of patients who are having functional diarrhea, they also may be having bile acid diarrhea or BAD. Antibiotic associated diarrhea disrupts the gut flora, and that way the bile salts, if there is bacterial overgrowth, the bile salts get deconjugated. So you are thinking the patient is having antibiotic associated diarrhea, but because if there is a extensive replacement of the good bacteria, then it is not antibiotic associated diarrhea. It is it is just masquerading because of the bile acid diarrhea. And sometimes what we think is refractory C. difficile colitis could actually be just BAD. So again, before you make a diagnosis of a recurrence of C. diff, it is, I think it's a wise thing, it's a pragmatic thing to just do serum C4 levels. And in case you get a value which is more than 52 or 53, then you know you're not dealing with recurrence of C. diff. It is just a case of BAD. Next slide, please. Next slide, please. So if you have a patient whom you think fits into the Rome criteria and you're treating as IBS-D, or if you go by the functional disorders, then you have a patient of functional diarrhea, then what will you do? In the back of your mind, it is possible you're thinking, I'm missing the diagnosis. Maybe there is some ulcers I missed in the terminal ileum. Could this patient be having Crohn's disease? Could this patient be having tuberculosis? And you end up doing colonoscopy after colonoscopy, which is common. And if you're convinced that there is no organic disease, then what do? You would treat as IBS-D, initially with the drugs such as clidinium or other drugs, and then you find the patient is just not responding. So the next step would be to add on antidepressants and then keep on going, whether you want to add SSRTI or the other drugs, or probably consult your colleagues in psychiatry. Or if you're not going on those lines, especially in people in the West, they would be very, very much inclined to start the patient on low FODMAP diets, which practically doesn't work in India. I have never seen, or I have rarely seen anybody who has tolerated a complete low FODMAP diet for more than 2 weeks, because our diet essentially contains in the north wheat, and in the southern part and in the eastern part of the country rice. So we have to take some kind of a cereal, and it's not very easy for us to follow the Western low FODMAP diet, or just having um, uh, meats with selected for some other, whatever the low FODMAPs are. Or if you think that you're dealing with some kind of a hidden infection, then you keep on giving these patients course after course of Norflox, Ciplox, O2, whatever you think, some lurking infection which cannot be diagnosed. So these patients are misdiagnosed, mismanaged, mistreated, and you end up giving all, if I can say, the wrong drugs except Coletran. Next slide, please. So I've already covered this, that what are the predisposing factors for bad. This is post-surgical, and one of the in the literature we always, if you read up this aspect, cholecystectomy is mentioned, but I don't remember the last time, or if I've ever seen a patient who has a cholecystectomy diarrhea which was due to BAD. Of course, we are not having testing for selenium HCAT, but next patient, if I get who's post cholecystectomy, I'm certainly going to do a C4 level. I've already talked about the extensive ileal resection, and interestingly, metformin-induced diarrhea is common. If you are working in a hospital multi-speciality, then you're likely to be referred patients who are having a chronic diarrhea. And if you go through their history, the important history, I think there are 2 or 3 drugs which I always ask. Apart from antibiotics, one is metformin, and the other is for idiopathic pulmonary fibrosis. It has a tongue twister, nanotinib, so we just call it as nano or nino, and that is the other drug. But metformin acts specifically by decreasing bile acid reabsorption on the receptors that I talked about, the ASBT. I've also talked about the extensive disease in the terminal ileum uh, or post-resection. And another important cause is radiation enteritis. Now, especially for those patients with pelvic malignancies where they give pelvic intracavitary radiation therapy, or in patients with CA rectum where we are using the SOP is to use neoadjuvant therapy in the form of radiotherapy and chemotherapy. The important point, the physiological point to remember is that a fair amount, the pelvis is like a basin. And in that basin, you have only 2 parts of the gut. One is the rectum and sigmoid, and the other is a fair amount of the ileum, which is lying. So when you give intracavitary or pelvic radiation, the ileum becomes the fall guy. By default, it gets damaged. So these patients with pelvic radiation, they can also have a BAD. Next slide, please. Next slide, please. So how do you start treatment in these patients? If you're suspecting BAD, as I mentioned, we don't have the luxury of having a serum HCAT showing a less than 15% reduction. We have to probably go by just C4 levels or empirically treat them with the Coletran. And the starting dose of Coletran that I use is 4 grams per BD. In the literature, they say you can start with just 4 grams, but that's hardly effective. And then you monitor, because you can go up, keep on increasing. The maximum limit that you can go up is 24 grams. We rarely need to go beyond 12 grams in clinical practice, but yes, as far as literature is concerned, then you can even go up to 24 grams and then titrate the dose once the patient gets better. Or you can if the patient is having pruritic disorders, then you can combine it. For example, in cholestatic viral hepatitis, or at least in patients with PBC, you can combine it with UDCA, and that is recommended by all the leading EASL, AGA, etc. They would recommend that you, in case you have a confirmed diagnosis of PBC, then you're justified to add ursodeoxycholic acid to your cholesterol for the control of pruritus. Next slide, please. Next slide, please. Now, I have more or less covered this aspect, but bile acid malabsorption, BAM, or BAD, bile acid diarrhea, they are synonymous terms. You can use either. So, BAM is now classified into 3 types: type 1, type 2, and type 3. So type 1 is the one that I've talked about in some detail, when you have extensive ileal disease, and the prototype of that is Crohn's disease, or when you have resection. So that's the type 1 and possibly the commonest. And type 3 is what occurs when there is a post-cholecystectomy, again uncommon, or there is SIBO. So these two would be the commonest. And type 2 somehow is the rarest, which is idiopathic, and it is thought that some of these patients may be having mutations in the ASBT receptor. So this is distinctly uncommon. If you have patients with BAM or BAD, most likely they're going to be type 1 and unlikely to be type 2. Next slide, please. So this slide shows you that, the stack of coins appearance, and what it tells you is that overall in BAM or in BAD, the efficacy is more than 70%. The best efficacy of coletran or cholestyramine is in severe BAM. If you have moderately severe disease, then it's less. Here it is 96%, and then it goes down to 80%. And if you have very mild BAM, then the efficacy is even lesser. This is 70%. Next slide, please. So the best results are those which patients have severe BAM. So here, again, the same thing. It's almost a repetition. If you have selenium HCAT, fair enough, or you go by C4 testing, you start with 4 grams per day or 4 grams BD, and then you gradually step it up. And I'll be talking about what instructions to be given to the patients later on in my talk. Next slide, please. So having finished the BAD or the BAM, we now go on to the liver aspects. And in some diseases, for example, in primary biliary cholangitis, intrahepatic cholestasis of pregnancy, drug-induced cholestasis, and perhaps the most important, which somehow missed over here, because is the cholestatic variety of viral hepatitis, which in India we have the leading 2 causes of viral hepatitis in the community are hepatitis A and hepatitis E. And some of these patients, a fair proportion, I would say, do have pruritus, which is the most distressing symptom. And this pruritus is because of accumulation of bile salts and other pruritogenic substances. They tend to accumulate in the skin and stimulate the cutaneous sensory nerve endings, which makes the patient scratch all day and all night. And the net result is the patient has a very poor quality of life. His sleep is disturbed and he has psychosocial issues. Next slide, please. So for cholestatic pruritus, this is almost the first line, except in those patients who have something like a bile duct ligation or a complete cutoff of the bile duct due to a tumor. In all other conditions which I alluded to in my previous slides, this is cholesterol is very effective, or cholestyramine is very effective, and it reduces the pruritus mainly because of the reduction in the enterohepatic circulation of pruritogens and the local action. So it is now recommended as the first line therapy in these cholestatic disorders. Next slide, please. And this is the study that I talked about initially when I was into. So this is a study by Dr. D.V. Datta, who was the ex-chief of hepatology at PGI Chandigarh. He was a student of Sheila Sherlock, and then he came back to India and set up the Department of Hepatology at PGI Chandigarh. And this was his paper in gastroenterology in 1966, in which he had, it's a small study, but it was an important, the first breakthrough for pruritus, possibly in India. We never had so much of PBC, but in the West, where it's common in Northern Europe. So 6 patients, very small study, but look at the impact that from 66 onwards, this is the first line drug for relief of pruritus in patients with PBC. The name has changed. The earlier name was primary biliary cirrhosis. We now call it cholangitis. So the initials remain the same, PBC. And in his study, in Dr. D.V. Datta's study, cholestyramine was given 4 grams TID for 7 days, and there was marked relief in the pruritus starting from day 3. And although it didn't change the liver enzymes too much, but there was a symptomatic relief, which is very important for these patients. Next slide, please. So the next question is, how should Coltron be taken for optimal use and safety? And here I can just tell you that first, it comes as in a sachet form and a powder, and which is to be dissolved in water. And unfortunately, it's not a solution like ORS. It's at best a suspension. So you can feel the granular things in your mouths. So it must be taken with water. And if you're taking other medications, then you take either 4 to 6 hours after or 1 hour before. And in case you are dealing with pruritus, then it's best taken as a breakfast drug or in the morning. And if in case you're dealing with BAM or BAD, then you take it after dinner. But you must be well versed with the fact that in some patients it causes not only nausea but significant constipation. Next slide, please. So what instructions would you give the patients? You tell them that it comes in a sachet, you mix with water, which is a non-carbonated, but it's just plain water. And as I said, it's not a solution, it's a suspension. And then you can gradually take it up. 4 grams TDS is a very common dose that we use in clinical practice. And as I mentioned, it can go up to 24 grams per day, although I have never used this drug in this dosage. Next slide, please. So to optimize the effectiveness, as I said, if it's pruritus, take it with your breakfast. And for all other diseases, especially the BAM and the BAD, is best taken after dinner. And as I already mentioned, that if you're taking other concomitant medicines, then you take those either 1 hour or 4 hours because it is a sequestering agent. It can bind to that drug as well. So you don't want that to happen. So it must be spaced apart effectively. Next slide, please. This is essentially just the same, that you have to warn the patient about the taste, the granular feel, and a slightly bitter taste that it has. And you have to tell them that, look, that if it's pruritus, then you may have the response may be a little delayed. It may be a week or so. But if it's bile acid, bam, response. You also have to tell them that because of its one of the important side effects being constipation, the patient must take adequate hydration and fiber. Next slide, please. Only 3 important nuisance value side effects, which is because this is a drug which is not absorbed, it's not going to go into the blood, it remains in the small bowel and the colon. And the most frequent or troublesome or nuisance value is constipation. In some patients, it can cause bloating, and nausea is also common. Next slide, please. Here, because there are some precautions that must be taken because it is a non-absorbable drug and it does not cause tachyphylaxis. So people have been taking it for very long, months to years, but because it binds the bile acids and impairs with the fat digestion, and bile acids are responsible in fat digestion as well as fat soluble vitamins. So there can be a deficiency of the fat soluble vitamins, which is A, D, E, and K, when it is used for a very long time. It may also impair absorption of the drugs as listed here. And as I mentioned, it is not effective and not indicated when there is a complete biliary obstruction, as occurs when there is complete bile duct ligation, which can occur at surgery, or when there is an extensive tumor involvement of the bile duct. Luckily, hypersensitivity with this drug is very rare. Next slide, please. I've already mentioned this fact that because of the long-term use and the interference in the fat metabolism, so these fat-soluble vitamin levels can be affected. So some of these patients may have, if there is prolonged use and vitamin K malabsorption, and this can cause a bleeding diathesis. So maybe after 3 months or 4 months, you can check the PT and INR and see. And in case that is so, then you can always give parenteral vitamin K. Vitamin D also, anyway, vitamin D deficiency is so common, and this being a fat soluble vitamin, long-term use will aggravate vitamin D deficiency, which again can be the best way to probably overcome this is to give them injectable depot preparations of vitamin D, such as Arachidol. Next slide, please. So this is just a summary. But in hyperlipidemia, we are not using it so much these days. We are mainly using it for bile acid diarrhea and pruritus. I've already referred to this, and is effective in most patients, whether we have the availability of the selenium HCAT or not. It is a useful drug in IH, intrahepatic cholestasis of pregnancy, IHCP. As I already mentioned, it is useful in bile acid malabsorption or bad types, especially the type 1, and it is useful in cholestatic pruritus, other than those conditions in which the bile duct has been ligated. Next slide, please. So here, when you practical tips are that if you want to start with a lower dose, start with say 8 grams per day, which is 4 grams BD, then take it up to 12 grams. And maximum, of course, as I mentioned, is 24. You get you have to get the timing right, whether you're treating pruritus, which is in the morning, or if you're treating diarrhea, then it will be in the evening. And most importantly, tell the patient, do not take the dry powder. It can actually cause a choking sensation because it tends to stick to the mucosa of the pharynx and the mouth. So that would be, very difficult for the patient. He will kind of choke. And space the other medications. Next slide, please. Tell these patients about the taste. And if those patients, they get constipation, then you treat them with either other drugs. Commonly, we could start with polyethylene glycol, go on with Dufalac, or manage the constipation accordingly with hydration, possibly increasing the fiber level. Monitor their fat-soluble vitamins only in those patients who are having this drug for more than 4 to 6 months. Next slide, please. So now 3 cases I'm going to discuss. The first one is a post-surgical diarrhea. This is an 87-year-old female. She had an aortic valve replacement, which was complicated by a CVA, and she was having 4 to 5 loose motions per day. She was complaining of fatigue and dizziness. Her initial workup showed a C. diff was negative, which is the first thing in an elderly patient who's, I presume, because she had a aortic valve surgery, would have been given enough antibiotics. So this was excluded by the C. diff, GDH, and toxin assay. Next slide, please. So this patient was treated in very low dose, possibly because she was 87 years old, 4 grams of Colitron, and she had a marked improvement in 4 weeks. And the therapy was discontinued after 2 months, which is good because she never got the opportunity to get any depletion of the fat-soluble vitamins. So in this patient, I presume that the antibiotics would have caused some kind of a bacterial overgrowth, which led to deconjugation of the bile salts. And this was taken care by Colitron. Next slide, please. So the important thing is why it worked in this patient is because, as I mentioned, possibly there was unrecognized BAM or BAD, which is common in elderly patients, or there was SIBO, or there was GI motility changes post-surgery, post-stroke. And this patient, whatever be the underlying cause, had a good response to a low dose of Colitron. Next slide, please. Second case, this is a 71-year-old female. She has long-standing IBS, IBSD, or functional diarrhea, and this patient has been having 6 to 8 loose bowel motions per day associated with severe abdominal pain, which makes her a candidate of IBSD because of the presence of abdominal pain. She has additionally comorbidities like a bipolar disorder and other cognitive impairment. And I think the physician in this case was not considering her elderly age and the psychiatric comorbidities, was not willing to give her any of the other drugs which are useful, such as SSRTIs or other drugs which we use commonly in younger patients. So she was started on Colitran 4 grams 3 times per day. And importantly, this patient not only responded but continued this treatment for 7 years. And that's because this is a drug which is not absorbed. I already made that point very all through my talk. And second, as it has no tachyphylaxis. So this patient, her IBS D was very well controlled for 7 years with Colitron. Next slide, please. The third case that we are, so this was the second case. Here, as I mentioned, that because of the bipolar disorder, the physician was reluctant to use any of the other medicines, and he chose to treat her with Colitran. Next slide, please. We've covered this case. Next slide, please. And the third case is severe cholestatic pruritus in a 54-year-old lady with PBC. And here, as is obvious, the first symptom of PBC is fatigue. And after fatigue, you get pruritus, and jaundice comes much, much later. So this patient had been having these symptoms for approximately 8 months, because PBC is a very slow disease. It seems that if PBC is a car, then it has only first gear for almost a decade before it goes into full-blown cirrhosis. So that's why this patient been having symptoms for almost 8 months. She had multiple excoriations because of the pruritus, very mild jaundice, and her liver test showed an elevated ALP 3 times, mild bilirubin only. So this is a hallmark. In the LFT, this is almost a signature LFT for patients with PBC. Bilirubin is in the range of 2, 3, 4, and the SAP and the GGT would be in hundreds. She has a positive AMA, which is diagnostic. There is no need for a liver biopsy in such patients. She had elevated bile acids, and because of this, she was having pruritus, which was causing sleep deprivation, fatigue, and even depression. Next slide, please. So as per the guidelines, if you have a patient with PBC, you can start with Colitran or cholestyramine, and then gradually, if there is loss of response or no response, then you can add the urso. But if the patient has intractable pruritus, then the treatment for these patients as of 2025 would be liver transplantation, because no drug can cause reversal of the LFT. No drug can cause reversal of the liver histology in PBC. So the only effective pakka treatment for PBC is liver transplantation. Next slide, please. So as I mentioned, this is only a stopgap arrangement for patients with PBC. It provides symptom relief in more than 3/4 of the patients, and it is effective only in patients who have in the earlier phase of the disease. Subsequently, these patients will behave like decompensated CLD, and ultimately, as I mentioned, they would require liver transplantation. Next slide, please. So when we are dealing in a patient who has presenting to us with vague symptoms such as fatigue, and she gives history of pruritus, always keep in mind that this could be PBC. Thankfully, it's not very common in Indians, but in a patient who is a Caucasian, a white, postmenopausal, with hypercholesterolemia, this will be the copybook case for patients for PBC. And this remains the first line therapy till the patient gets severe symptoms, and that would warrant a liver transplantation, as I said earlier. Next slide, please. So this is case 4. I think this is the last case. We're running out of time. We've already been there for more than an hour. This is a 52-year-old male. This would be type 3 L3 Crohn's disease, because there's involvement of the ileum as well as the cecum. So this patient has had a right hemicolectomy and extensive ileal resections, and is now having a persistent watery diarrhea. Previous management, as mentioned on the slide, is patient was given loperamide, low-fat diet, etc. None of the things worked. And then it must have struck the clinician that this patient has had extensive ileal resection, and so it must be the bile acids which are playing havoc. So next slide, please. So this patient was started, this would be severe BAM, and you can see a type 1 BAM in which there is resection of the terminal ileum. So the best drug in this patient would be cholestyramine or colytran, and in early intervention would mean earlier symptomatic relief, and you would have to titrate the dose because this is a permanent condition. The patient has lost, resection has been done, his ileum is not going to come back. Next slide, please. So this is my last slides. The takeaways are we are going to use colytran in gastroenterology primarily for two conditions, which is bile acid diarrhea and for cholestatic pruritus. And the advantage of this drug is it is non-absorbable. It is a sequestering agent. It binds the bile acids and prevent them from acting on the colon where they cause diarrhea or getting under the skin where they cause pruritus. It's a cheap drug. The common side effects are constipation, bloating, and nausea, and it has a very powdery taste, so it must be mixed properly with water. I think this is my last slide. Thank you very much for your patient listening. I'll be happy to take questions and pass it back to Dr. Ashok.
Thank you, sir. That was a very lucid talk. You covered in detail almost most aspects of cholestyramine. Now I have been told that there are over 6,000 registrations for this webinar, and we have received more than 600 questions. So it won't be feasible to 600 questions, but we have selected around 10 that we will be discussing. So I will start with Dr. Siva Prasad. Sir, you are one of the most senior, most gastroenterologists in the country at now, and practicing since 1980s. So how do you see this journey of cholestyramine?
Yeah.
During your time and what are they
Yeah, I think
now?
that's interesting because for all these decades, the primary treatment of pruritus has remained cholestyramine, right? Even in the 80s when I was doing MedM and even till today. We do not have anything to replace it or even not to improve upon it. I think that's a fact that the primary treatment of pruritus due to liver disease has remained cholestyramine. And what physicians should understand also that other treatments for liver disease, especially UDCA is given pretty often for most liver conditions, they don't act so well on the pruritus. They're not really, the UDCA does help improve liver function and PBC and does help to bring down enzymes. And it is a good drug. I'm not criticizing it. But you realize that the anti-pruritogenic effect of UDCA is actually low. Only in intrahepatic cholestasis of pregnancy does it have that UDCA directly takes care of the underlying problem and relieves the pruritus. But when you're treating, you want to give relief of pruritus, almost always there are other new drug agents available, but we have been depending on cholestyramine for these decades. And when you combine cholestyramine with UDCA like you would for PBC, then you have to make sure that the two are given at separate times. You give, as Amarender had explained, you give pruritus in the morning and afternoon, and you give a long-acting UDCA in the evening. So that would be that would be necessary to keep in mind as to what you're giving, why you're giving, especially in treating liver disease. And as far as pruritus relief is concerned, we are fully dependent on cholestyramine.
Yes, sir. This year we had we can say, epidemic of hepatitis A, especially in North India. We see a lot of cases.
Yes.
And we have seen so many patients in cholestatic phase, prolonged cholestatic phase. And most of the physician has prescribed everything, means UDCA, acetylmethylmethionine, Lola, even lactulose, everything. But the main symptom that concerned patient was pruritus, and cholestyramine was not in the picture in most of the prescription that we saw. So somehow that there is a lack of awareness about this treatment of pruritus in cholesterol. Now, my next question is to Dr. uh, Rishikesh, are you there?
Yes, sir. Yes, I am there. Yeah.
So in your experience, I want to know how often you prescribe these drugs for, diagnose this drug for IBS-D type patient where you want to treat for bile acid malabsorption.
So first of all, as AS Puri sir has already discussed, we tend to miss this bile acid diarrhea as a diagnosis. So first, it is sort of a last resort only. We will try all other medications, rifaximin, try empirical therapy. Then we'll rule out other celiac disease and other chronic GI disease like with the help of endoscopy and biopsy. And after that, only other things are ruled out. The SIBO is ruled out. Then we will go for the empirical coltran therapy as a trial, just to avoid the bile acid diarrhea. So we don't use frequently coltran as a treatment for diarrhea.
Okay.
I
This
think, I
question.
think the point has been highlighted about the difficulty of diagnosis. We'd really like to have a method to easily diagnose bile acid diarrhea, which, as Dr. Puri had highlighted, it's extremely, we have not yet crossed that hurdle as to how to make a diagnosis in clinical practice outside of study
Empirical
research
treatment.
settings. Yeah. So we, as most of the time, it's like, okay, we've tried everything else. Let's just try this, which is really not ideal.
Really not ideal. I agree, sir. We are using empirical treatment most of the time when everything fails. Puri sir, I want to ask, what is the sensitivity and specificity of C4, that basically level, to diagnose this bile acid diarrhea? Basically, how sensitive it is and how often we
Sensitivity
can treat.
is to the tune of 60 to 70%, but a value greater than 54, I think it's very specific, almost 90% specific. So this test is specific, not very sensitive.
Okay. So at least then we
But
can
again,
label at
Ashok,
least.
I would clarify this. This is data only from the West. I'm not aware of any study on C4 and BAM in India. So, although I have given you the figures from the West, I don't know whether they will be duplicated in India. Until somebody does a study, only then these figures will hold good.
Okay. So my next question is to Dr. Devanik Sardar. Sir, are you there? Dr. Devanik?
Yes, his camera is off and is still muted.
Yes, I'm there.
Okay.
Okay.
Yes.
Sir, I want to ask, when do you start cholestyramine as the first line therapy in cholestatic pruritus, or do you want to use as adjuvant therapy?
In case of pruritus, when the main complaint of the patient is pruritus, I usually start cholestyramine. Not often as adjuvant, but when pruritus is the main complaint, I right away start it. But when it is not a main complaint, then of course sometime with the UDCA or any other drug. But mainly when pruritus is the main complaint, I wouldn't hesitate to start cholestyramine because it does give good results, and it, as sir has pointed out, for several decades it has remained the standard therapy for the pruritus. No better drug has come.
Now, Dr. Puri sir, so what all drugs are you using for pruritus other than cholestyramine? I have worked under you, so
So, in addition to what we've already discussed, what I use is rifampicin. And rifampicin, I think even in a dose of 300, maximum 600, it is useful. And when nothing else works, then I use naltrexone. Cetirizine, of course, is used. Antihistaminic is used very commonly. But apart from Colitran, UDCA, cetirizine, the other two drugs, as I said, are rifampicin and naltrexone. Yeah.
that's what I want to hear. So
Yeah, I would like to emphasize that the itching of pruritus is quite different from the itching of allergy or something that is histamine responsive. So in most of those situations where due to an allergy, itching kind of relieves the pruritus. When you scratch, you feel a little better. But cholestatic pruritus, itching actually worsens it. Really not. It's a very difficult symptom to characterize, and it's not. Even when you say pruritus, that pruritus is qualitatively different from the pruritus that may come with a simple allergic reaction. I think we should keep that in mind. And it's extreme short of treating, removing, taking the pruritogen out of the circulation. it's very difficult to relieve directly the symptoms of pruritus, which is what cholestyramine does.
So
Just
basically,
wanted to discuss regarding use of sertraline. How often you use sertraline as a treatment for pruritus, because it is given in the line of treatment as a third line therapy, but most of the time coltan does the job. And also wanted to discuss regarding the new EASL guidelines for primary sclerosing cholangitis patients mainly. They have mentioned rifampicin as first line therapy for pruritus. They have not mentioned coltan. So what's your take on that?
Who is the question addressed to? Is it to Shiva?
Sir, Dr. Rishikesh, sir. Dr. Rishikesh.
sir, you are the best person to tell.
No, for PBC, yes, the first drug remains colytran or cholestyramine, but for as you mentioned PSC, here probably you can use either. And the other question that you asked was for sertraline. Sertraline is a antidepressant drug that is used, and I have not used it for this indication. Uh, most clinicians won't be very familiar with the use of this, other than a small proportion of patients who would have severe IBS, which jokingly I say malignant IBS. The patient will not leave your OPD and will come with long lists. So they are the ones, but always you should take into account your psychiatry colleagues when you prescribe these drugs, specifically in elderly patients or not so young patients. But I have no personal experience of using sertraline for pruritus, although it is mentioned. I have also read it in the literature, but I have not used it, so I cannot answer your question.
Shiva sir, have you used sertraline?
No, really, it's not come to that. Ondansetron has also been described as relieving pruritus, but really, as Amarender has mentioned, with cholestyramine and rifampicin and maybe something like that. By which time you have addressed the problem to go on sertraline primarily because all the drugs have failed at level 4 to be used. I've not really also encountered that situation where your patient has such severe pruritus, nothing else is working, and sertraline has been given and working. I really can't imagine that situation, though it's there in the guidelines. I agree.
Okay. Now,
Thank you, sir. Yeah.
Dr. Rishikesh, this question is to you. So, what do you think are the common barriers of prescribing this cholestyramines? Why it is not so commonly used? I told.
First of all, lack of awareness regarding the use and effects of cholestyramine, most probably.
Yes.
Second,
The company that make the cholestyramine, no other company is even promoting. So
yes,
they are
lack
not
of
reaching
awareness.
most of the clinician with their indication. That we can also say. Yeah. Next.
And second, maybe regarding its interaction with other drugs, it decreases the absorption and other interactions is there. So
You
maybe
can't take the other drugs at that,
yes,
as sir told. Either you take the other drugs 1 hour before or 4 to 6 hours later. So that
yes.
is also sometimes patient may be limited. Anything else in your experience? Anything about taste or that you have felt use? Whenever we
No,
use
I think the fact that there's only one company,
yes,
promoting cholestyramine actually acts to its disadvantage.
yes,
If you all realize that Gaviscon, which was the anti-arginic antacid, was there for years and it was just a niche product. Suddenly the rafts came in, and in the last 1 year, 20 or 30 companies have all come out with one raft or the other, and suddenly the entire antacid prescription has shifted from conventional antacid to raft-based antacid, though Gaviscon was there for a very long time. So I think probably that is also what's happening. When there's only one company that is promoting the penetration, the awareness, all that does suffer a little. So, and then the second point about practical use, you can't just prescribe it like a tab, like you prescribe UDCA, just 1 mg or something like that. You have to sit down and really explain to the patient how to take it, when he should take it, what are the side effects that you should avoid, and all that. You have to pay that little attention to giving a prescription.
Yeah, but I just want to make a point that cholestyramine was there even when we were residents, and that time I think it was sold as Questron. I think
That's
most
right.
of your
Western is an international brand.
yeah, and now Ajanta Pharma is actually a late entry. I don't know which year. So now we hardly see Questron in the Indian market. They've done a good job, and we see Colytron everywhere. And one of the main reasons for this might be the cost of the drug was considerably reduced when Coletron came into the market vis-a-vis Questron.
No, Coltrane has been there for decades. I mean, even at the, I would say, late 80s, 90s, when I started practice, the cholestyramine that I was prescribing was Coltrane. Questran wasn't easily.
Questron was the first to come, and then
Questran was the first drug, yeah.
In my practice, I have seen only Coltrane till now.
Yeah, that's what I'm saying. Even I have hardly prescribed Questran in practice.
Okay. So what is a negative effect we can say of the taste or this thing on the patient?
Yes, yeah.
That I want
The
to
practical aspects about how to take it and the taste and the fact that you have to make sure that the juice and at the right time, all those things should be other main limitations. I think to wider kind of easy acceptance. That's all. But efficacy wise, I don't think there's any, nothing to. There's no competition basically in this space.
Oh, next question to Dr. Devani. Sir, have you seen any means on prolonged use any vitamin deficiencies on these patients, or how do you monitor those symptoms of soluble vitamin deficiencies?
Well, I have used it not for that long that I would be encountering vitamin deficiency, but as per literature, I mean, they do recommend that fat soluble vitamins, namely A, D, and K, should be monitored. So, and also especially vitamin K with the P time and INR, because that might cause even bleeding. So I've prescribed it for a few weeks or so, not for years as most of the cases here have suggested. But I have not encountered major deficiencies of vitamins. Most of the patients have complained of taste, and most of them have said that it tastes very weird. So I have often advised them to take them with non-carbonated drinks or to dissolve them in large amount of water so that peculiar taste goes away. But other than that, most of them haven't complained much.
Yes.
And
encounter this deficiency when we are prescribing for long term, like PBC.
No, I think the underlying liver disease warrants fat soluble vitamin supplementation. I think that is a simpler strategy than trying to monitor the deficiencies. The patient anyway needs fat soluble vitamin supplementation, and that should be prescribed for every patient with cholestasis. And okay, then you look, if there's a doubt, you can maybe check for vitamin D or something like that. Yeah, and I think the kind of citrus fruit juices are the ones that best mask the taste. Lime juice, orange juice. These are the ones that best mask the taste of
yes, sir.
Coltrane. Plain water actually is probably more difficult for the patient to take with plain water. A strong, juice like orange juice or lime juice would be better.
Now, sir talked about some indications like metformin-induced diarrhea. You can use cholesterol. So how are we using that, sir?
Amarender, I think I'll leave that to you. I mean, metformin is an enigma. What causes, the symptoms? How to tackle it?
The metformin diarrhea is not a single factor; it's multifactorial, and the bile acid diarrhea is one of those which is postulated putative factors. But in this patient, in those patients whom I suspect has metformin-induced diarrhea, I usually send them back to my colleague in endocrinology and ask her whether she can take off metformin and substitute it. And invariably, it has worked. So I have not used.
So there are a lot of
for this. Yeah.
nowadays available.
But you still like to give metformin. I mean, I think that's still the foundation.
Yeah, but some patients don't tolerate it.
They don't tolerate it.
Very troublesome diarrhea.
Yeah, I know.
There are so many drugs for diabetes now that sky is the limit.
You have choices.
So you have a choice. It wasn't like 30 years ago.
Absolutely.
Change the scenario. Now, sir, also I want to ask of refractory C. difficile diarrhea. How commonly are we going to use it?
You are talking to, are you asking me, Ashok?
Yes.
Okay, so I have actually worked on 2 theses done on C. diff diarrhea. Recently, we've just finished one, and surprisingly, as in India, the prevalence of C. diff diarrhea, I don't know the reason, is less than 5%. If you go by the proper guidelines, which means that you have to have GDH positive, toxin A and or B positive. So you need to have both GDH positive. In fact, many people first test for GDH. We don't do that. We do it simultaneously. Then GDH positive, toxin positive, you have C. diff. So the frequency that we found in patients with moderate to severe ulcerative colitis, more than 150 patients, is just about 4%. And surprisingly, as compared to the West, C. diff in India is milder. We didn't have even one patient who developed toxic megacolon or required colectomy early stage for the TMC or toxic megacolon. And most of our patients, and not most, all of our patients responded very well to a combination of Vanco plus Metro. So we use this combination of Vanco plus Metro, and it works very well, and not a single mortality in 150 odd patients. So since these patients responded so well, and I myself surprised as to why we don't have recurrent C. diff like is described in the West, that they have to go not only from Vanco to Fidaxo, from Fidaxo they have to go on to, FMT. So it seems the spectrum of the disease is much milder in India as compared to the West.
Now, I have just a hypothesis about that. We know that C. diff is related to use of antibiotics, and we wonder why when antibiotic usage is so much in India, we don't have C. diff. And my reading is because antibiotic usage is so much in India, we don't have antibiotic-induced dysbiosis. Because everybody has been taking so many courses of antibiotic all their lives, the chances of a single course of antibiotic causing sufficient dysbiosis to trigger the C. diff infection actually comes down. Okay, this is just a way of thinking. So
this is like saying, Shiva, this is like saying that you have 2 drinks every day, and that will not harm your liver. But if you have binge drinking, you have the guys have never been exposed, and the guy gets C. diff.
Yes.
Maybe.
Maybe microbiota related things is difficult to predict how they are.
Yeah, that's exactly how the microbiota are changed with any antibiotic in our digestive systems is something we don't really understand or know too well.
But definitely this C. difficile severity is less in India.
No, the frequency itself, the chances of proven C. difficile, as Amarender showed, it's very low and the severity is less. So C. difficile, really, even I don't have much of clinical experience with C. difficile.
Puri sir, your patients are IBD patients or they were general patients?
No. I took specifically in patients with IBD, and not only IBD, we selected only patients with ulcerative colitis, moderate to severe disease. Now, there has been one study only, one study from AIIMS. They had, again, 120, 130 odd patients, Vineet's study, and they had a solitary patient, just one patient who was C. diff positive, and in that study, they didn't even do GDH. So we don't even know if it was a true positive or a false positive.
No, we also have data of around 120 ASUC coming up with 10 C. diff positivity. Will be also coming that.
Okay.
Yeah. So it's around 8 to 10% prevalence in our setup, sir, C. diff in IBD at least. But non-IBD patient, how common? Basically, that's what I.
Non-IBD patients, it's much more common. And if you want to discuss it, see, if you have an elderly patient who's in the ICU, 70-year-old patient is with pneumonia and she gets a diarrhea, they are the ones you'll see the pseudomembranes in the rectum.
Yes, sir.
In IBD, you never see a pseudomembrane. Never. I have never seen in the last 10 years, never seen a pseudomembrane. They don't have a normal colon. So, you want. Whereas in these patients, so we see C. diff more commonly in non-IBD as compared to IBD. And in IBD, you can still get C. diff without a proper exposure to antibiotics. When we took their history, I think only about 12 or 15% had been exposed to antibiotics. But in non-IBD elderly patients, 100%.
Yes.
100%.
Usually these are elderly patient admitted in ICU for long time for knee transplant, for some other surgery or some pneumonia, CVA, and they get diarrhea because lot of our audience is physicians today. It is important for them to consider about C. difficile diarrhea. You treat them with metronidazole, vancomycin or fidaxomicin. If not, then you can add cholestyramine also. So now, Siva sir, what are the future prospects you are seeing? Where does cholestyramine will stand?
I think where it has stood for the last 40 years, it is going to remain the same. We don't have a choice. We don't have a better alternative. And it is an effective treatment for pruritus. So I think that stays. There was another bile acid binding resin called Cholestyramine. I think that was the name had come up in between for a while, but it never came onto the market and it never, if there is a new kind of resin that can be synthesized that might have less of the problems of cholestyramine in terms of administration, then maybe. But I really don't see that happening. I think we are, as far as relief of pruritus is concerned, we are still dependent on cholestyramine for the foreseeable future.
Yes. So with this, we have considered most of the questions. The other questions, most of them were already answered in the sir's talk. So with this,
yeah, I think, if
Sir, I have one question. The literature mentions that there are some issues with called hyperchloremic acidosis in certain patients taking this cholestyramine. What is your take on that? I mean, is it not safe for patients with kidney diseases?
See,
what acidosis, sorry?
Uh, hyperchloremic acidosis, that is what the
Hyperchloremic acidosis, I have no idea. Amarender?
they said that there is some issues with in patients with renal impairment. I mean, there is no dose adjustment required for hepatic diseases, but for patients with CKD, for example, there may be some issues. So there is some warning on usage of cholestyramine in such cases.
Dibanik, I think there must be a couple of case reports only. I don't think it's a very well recognized.
No, I'm not
Because
sure.
the primary thing is that it's not absorbed. So
Yes.
unless it gets absorbed, goes into the circulation, damages the kidney, only that. So that's why I think you may have read some case reports. Otherwise,
Okay.
the manufacturer also does not mention this.
okay.
Okay. Can we, I would need to leave now. Is that okay?
Yeah, I think we can wind up.
We have
Ashok.
covered up most of the topics.
Yeah.
I
Okay.
think most of the people must have got a good knowledge and awareness about the uses of this wonderful drug that has been there for last so many years. And I will like to thank Puri sir for this excellent lecture. As usual, he took it like a artist mastery over the people presentations. I will also like to thank Shiva sir, his experience, and he told so many nice things and gave so many gems of knowledge. Also like to thank other panelists, Rishikesh sir and Debanik sir. And thank you, Ajanta, for organizing it. And that's all from us, our side.
Thank you.
Thank you, everyone. Thank you.
Thank you so much, sir. Just a bit of vote of thanks that I want to express on behalf of Agenda Pharma. So, on behalf of Agenda Pharma, I extend my heartfelt gratitude to our honorable speaker, Dr. Amarender Puri, sir. First of all, for giving us this time and getting this the knowledge of cholestyramine propagated to today. We have got 1,500 doctors all across India who had touch base live on this webinar. So thank you. It's a working day and it's a busy day today. But this seems to be so interesting that a lot of doctors have already asked us to give us the video bites of the same. And we also thank our moderator, Dr. Ashok Dalal sir, to moderating the program and making this discussion so interesting, choosing the best of the questions and asking them to the right panelists. We thank Dr. Shiva, our panelist, Dr. Shiva Prasad sir, Dr. Debanik sir, as well as Dr. Rishikesh Malokar sir. for their valuable addition to the discussion and enriching this knowledge. A big thanks to all our doctors and SCPs who had connected on this busy day on Tuesday for getting an enriched knowledge on cholestyramine. This is the first ever webinar that we have conducted in the country, and we thank all our esteemed doctors to be part of this program. Our gratitude, we from Agenta Pharma always are committed to supporting continuous medical education, and that will support better patient outcomes. So thank you all for the same. And thank you to the technical team from DocMode and our medical affairs who had supported us from the back end and the technical team. So thank you all. And with this, I will say that we can close the curtain on this today's webinar. Thank you so much.
Thank you. Good night.
Thank you. Good night. Good night, Ashok. Good night, Shiva.
Good night,
Good night,
everybody.
sir.
Thank you, sir. Thank you.
Thank you, Aparna.
Thank you, sir.
Can I stop live?
Yeah.
Thank you so much, everyone.